I chose today's topic, self-injurious behavior, for two reasons. One, for this year of SZconsult didactics, we're going to branch out and include clinically important topics. Reason number two for choosing this, self-injurious behavior, is a clinically important topic. As I'll talk in a second, it's not though it's not a standalone diagnosis, it's something that happens with great frequency. Depending upon which segment of the population you're talking about, between 5% to 30% of people engage in non-suicidal self-injury. And because it's not a, if you will, standalone diagnosis, and because it doesn't have an approved prepackaged treatment to go with it, individuals that engage in non-suicidal self-injury frequently come to clinical attention, and their representation in clinical care is much higher than in the general population. So with that so I hope today to give you an overview at a fairly high level about some of the ideas around cause of self-injurious behaviors and treatment ideas. So starting off, we're going to do some defining and focusing. Self-injurious behavior can occur as a suicide attempt or in conjunction with suicidal ideation. It can also occur without suicidal ideation or intention, and we're going to focus on that, specifically what's called in the literature typically non-suicidal self-injury. And non-suicidal self-injury is usually defined as, the name would suggest, is deliberate and intentional damage to the body without suicidal intent. Common forms of non-suicidal self-injury include self-cutting, burning, scratching, or hitting. There can be others, of course, but those are the ones that usually most commonly show up in clinical practice. So, and this is not, I think anybody who works in psychiatry or mental health knows this is not a uncommon problem. If you look at the general population, somewhere around 5 to 6% of adults will report having engaged in self-injurious behavior. Those numbers are higher amongst the younger you go in the population demographics. So around 8% of pre-adolescents report engaging in non-suicidal self-injury. And amongst adolescents, the rates are probably climbing. So historically, they've looked at around 15% prevalence, but some estimates are pegging it at maybe more than a third of adolescents will engage in one or more episodes of non-suicidal self-injury. And so, of course, clinical samples are enriched in pathology. So we see in clinical samples depending upon the setting, between 12 to 80% of patients will have engaged in this behavior. This almost goes without saying, but this is an important problem. People who engage in this behavior can have wounds that range from superficial and temporary to deep and permanent. These behaviors and their consequences can be associated with severe impairment of function and life quality. And there's a paradox here, because people that engage in non-suicidal self-injury as a whole have a higher risk for later true suicidal behavior. Ribeiro has pegged the odds ratio at about 4-fold over the normal odds of suicidal behavior. So although globally it increases the risk or the likelihood for suicidal behavior, people who engage in non-suicidal self-injury are often thought to do so as a form of avoiding actual suicidal behavior. So it's a paradox. Probably the non-suicidal self-injury, as we'll talk about soon, discharges some tension, and that, at least in the short term, with respect to talking about suicide, might be protective. So, very important point, non-suicidal self-injury, just like almost every other major diagnosis in psychiatry, is not a standalone, uniform entity. For most psychiatric diagnoses, including non-suicidal self-injury, there are multiple underlying biochemical pathways and multiple psychological factors and multiple environmental triggers and so forth. So, you get a call, hey, what do I do about this? Looking for a simple answer is not going to work. You need to think carefully about the combining influences that lead to this behavior when thinking about responding to it. And non-suicidal self-injury is typically associated with many other psychiatric illnesses. Common ones are depression, anxiety, and PTSD. I'm going to focus on that family of NSSI during this talk. People with autism spectrum disorders, as well as people with psychosis, can also engage in non-suicidal self-injury. Those are, we'll say, special considerations that we're not going to have time to address. So we're focusing on the more common forms. So non-suicidal self-injury, it has a role. It usually, if not almost always, serves some function. This is a diagram that was done by Taylor et al. In 2018. And they did surveys of people who engage in these behaviors, and they tried to parse out what is the role that it serves, or how did it function. And so they broke, as a first cut, the majority of people who engage in this behavior do so for intrapersonal reasons, to regulate emotion, or to engage in self-punishment, which is usually a way of regulating emotion. A minority, between a third to around a half of the sample, engaged it for interpersonal functions, to communicate distress or to influence or punish other people. So it's, in my experience of working with people who engage in these behaviors, a lot of times the patients are not really aware of the functions that it serves. And in my experience of consulting with physicians, it's also not uncommon that physicians are not clear on this point. It's very helpful to delineate this in an understanding and empathetic and non-judgmental way, to try to understand, so you engage in this behavior, what happened afterwards, what happened before, what tensions were relieved, or what was gained or lost. You're trying to ask questions to get to the point of more or less, what problem does this solve, which is another way of phrasing how does this function. Understanding that is useful. It oftentimes, not infrequently, gives a first level of insight to the person who engages in these behaviors, and that can be a very useful frame for talking about further treatments. Speaking of treatments, then, there are a lot of studies have looked at a variety of, if you will, psychotherapeutic or psychological approaches. The ones that have the best literature for effectiveness revolve around emotion regulation, and the treatment modality with the most literature and best evidence that revolves around emotion regulation is called dialectical behavior therapy. So I want to take a few minutes to talk about DBT, so we can get a clearer understanding of what this is. DBT is a psychotherapeutic technique that focuses on these four components: distress tolerance, emotion regulation, interpersonal effectiveness, and mindfulness. Mindfulness is kind of an overarching theme, because mindfulness means being aware of what's happening inside, and having this sort of global awareness about, to what extent am I in distress, or what emotion am I feeling, and what can I do about it. The mindfulness is the mental faculty that allows the patient to be effective at these other very important elements. So distress tolerance, emotion regulation, interpersonal effectiveness, wrapped around mindfulness, is what DBT is trying to accomplish. And how it works is, I think a very good analogy is kind of like a classroom with a teacher. It works like in school you have textbooks. In DBT you have a manual. In school you have a teacher and classmates, and in DBT you have a therapist and a group. Skills are taught and discussed in group sessions, and therapists provide crisis intervention, which typically involves coaching and assistance with the effective use of skills. Very simple, and I think the next slide is going to tap again into this classroom analogy. Um, it's useful to explain DBT to people as follows, that the ability to recognize and regulate emotion is a skill identical to the ability to learn to ride a bicycle or speak a language or play a musical instrument or hit a baseball. These are all skills which we're not necessarily born with, but with practice, we can easily acquire. I like using foreign language and musical instruments because everybody knows that they can accomplish these things if they have the desire to accomplish it and have a structure to learn that. And DBT regulation, awareness and regulation of emotion is exactly the same thing. When we learn a new language, parts of our brain remodel itself to make it easier to acquire the words that we need and phrase them in the ways that we want to communicate our intents. And similarly, when we ask the brain to recognize emotion and to regulate emotion, the brain complies with our wishes. This was demonstrated very dramatically by Goodman and colleagues who did a very basic textbook DBT course, and they had a group of people that were involved in basic DBT 101 and a comparison group, and amongst people with borderline personality disorder in treatment as usual versus DBT. It was found that DBT works, and that ability to reduce impulsivity and improve emotional regulation correlated with changing how the amygdala responds to stressful situations. The amygdala is a center in the limbic system which generates fear as well as other negative emotions, and in people with borderline personality disorder, essentially the amygdala is hyperactive or overreactive. DBT normalizes that. So using this, I think very deeply and very often about using this analogy, and it continues to be useful on every level that I can think of. And explaining it in this fashion, oftentimes for people who have engaged in recurrent self-injury, they'll be grateful for this, because unfortunately, a lot of people in the profession are not doing a great job at explaining what that entails. So that's the, if you will, the gold standard psychotherapeutic approach. Of course, it goes without saying, but I'll say it, that that for a person who has non-suicidal self-injury, you should look to see, are there other psychiatric diagnoses that are relevant that I can treat. Depression, anxiety, and PTSD will be common, and treating those with psychotherapy and or combination of psychotherapy and medication will also be helpful. And coming back to the problem of not a standalone diagnosis for which we have an approved drug, we have a literature which is, I think, diverse and sparse. It doesn't lead to a clear answer for pick this drug treatment and see some reduction, but there are some clues and some literature that support dopamine receptor blocking, the use of antidepressants, and centrally acting norepinephrine drugs, clonidine and prazosin I have in mind for that, naltrexone, and a young and tantalizing literature about N-acetylcysteine. How do these work?
There, I got it.
There we go. All right, we'll let you get back to it now.
Okay.
Hey, were you able to make any progress in doctors first, or is that still giving you trouble?
So for those who have their mic open, could you please mute? Thank you. So we have this list of medications that have some evidence for helping at least some people in some situations. I'm going to explain how these things might work. So dopamine receptor antagonists, there may be two mechanisms. One, these drugs in general at higher doses diminish the noxiousness of stressors. They also unfortunately diminish the pleasurable events. But if the world or the internal milieu are giving a person overwhelming noxious stimuli, then perhaps blocking dopamine receptors makes that less noxious and allows the person to deal with distress through other means. There's also a literature that suggests that for some people, to some extent, engaging in non-suicidal self-injury has a rewarding quality. There's a function that it serves and a sort of reinforcement signal that comes around from that, and dopamine blockers can block those signals as well. Antidepressants, SRIs, NRIs, and bupropion all have some literature to suggest some possible benefit. Presumably they do this by reducing the global level of distress from depression or anxiety. There's also on a neurochemical level, many people with an SSI will have very low levels of serotonin metabolites in their cerebrospinal fluid, suggesting, at least for some cases, that there's deficient serotonin signaling. And so giving serotonin boosting drugs might help that subset of the population. Next slide, please. The centrally acting anti-epinephrine drugs, clonidine and prazosin, may disrupt sympathetic arousal, and so that there's a signal for some possible efficacy for that approach. A common finding, it's not universal, but several studies come up with the same result, which is to suggest that some people with non-suicidal self-injury feel less pain than people without. There's an endogenous analgesia. Amongst people who engage in cutting behaviors or other self-injuries, a common statement from that group is, I get numb. It usually goes like this: I feel something happens which gets me very distressed. The emotion builds up to a point that is overwhelming, and at the same time, I feel numb. I can't feel anything. They're describing analgesia, and so I cut, they will say, so that I can simply feel something. So the theory exists that this high level of analgesia is related to high levels of circulating endorphins released by stressful situations, and that cutting or self-injury occurs in that context. So giving people naltrexone may reduce that endogenous analgesia, and to the point that there is a reinforcing quality with self-injurious behavior, naltrexone may block that reinforcing signal to some extent and contribute to the extinguishing of that behavior. And N-acetylcysteine, we've hinted at this in a couple of other previous talks. It's a glutamate modulating drug. Exactly how that translates into decreased urge for self-injury is really poorly understood. But there are animal models of self-injurious behavior, and glutamate modulating drugs seem to help in those models. And the people who explored NAC in humans basically looked at the mechanisms of action of topiramate and lamotrigine, which have some literature to support helpfulness, and found potential benefit. So the literature on this consists of 2 case reports and 1 case series, as well as some papers in people that have self-injury related to autism. But interesting drug because it is relatively less side effect prone than other choices. So to summarize, for when we're confronted with the clinical situation of a patient who engages in non-suicidal self-injury, the first step is to understand how that behavior functions, what role it serves, what need does it meet. That can oftentimes provide some insight for the patient and some insight for the clinician to guide rational therapy. Rational therapy almost always consists of rational psychotherapy. Rational psychotherapies will understand self-injury as a way to regulate emotion or to get some external event happening, and to design therapies around correcting those spheres. It's very important to screen for other psychiatric illnesses and make sure that we're treating those. Medications can be used, but in my mind, the great risk of medication is that will focus the mind of both patient and clinician on looking for medication solutions when both should be focused on trying to understand it from a psychological or environmental standpoint. And we need to do that because we have very little evidence in literature to guide rational pharmacotherapy. Nonetheless, several drug classes exist, and it certainly they can be employed on a empiric basis. When using any empiric therapy, it's important to document the rationale for choosing the drug. It's important to try to estimate the frequency of the behavior you're trying to change prior to drug treatment, and then making sure that the drug treatment is effective. It's worthwhile to continue with renewal of informed consent if the drug treatment is effective, and it's important to not continue drugs that are not proven their worth in modifying the behaviors as desired. So that is the end of those remarks.